That's why they changed. I was to go actually tomorrow morning, but
Okay,
then they
okay. That's
changed.
why I asked you. That's why I asked you today whether
No,
you
no,
are
that's right.
available or yeah.
I am available tomorrow night. By this time I'll be
Okay.
in Mangalore.
Yeah, yeah.
Sunday I have 2 sessions.
Last time you didn't come, I was there.
I know I was not there. This time
Yeah.
Sri Krishna sent the tickets and said you have to come again. They have given me 2 cases. I don't know what they are going to do. 2 case presentations. I said, okay.
For good cases and they present, yeah.
I think Bangalore also has 4 medical colleges, no?
Mangalore has got 6 or 7 medical colleges.
Oh.
Yeah, now I don't know. It was 4 initially, now probably 7.
No, now 7, sir. 1
Yeah.
government and 6 private.
Yeah. Of course, Kasturiba was the first private, then government came, then of course other things.
Dr. Snail will join little late because of our webinar elsewhere. So
Shall we start, sir?
We can start, sir.
Yeah.
Okay, you can students, you can introduce yourself and then you can start.
Yes, okay. I'm Dr. Akash and Dr. Mona Lisa is with me. We're residents. I'm a resident JR3 here in Apollo Hospital and Dr. Mona Lisa is resident 2. Hello?
Yeah, you can start your presentation.
Yeah.
Your PPT
So
is
we
not
are discussing.
PPT is not
PPT
seen.
is not.
Yeah, before they start,
Yes,
I want to admit that today's session is more a learning exercise for somebody like me than for the students. Because I'm not a neurologist,
Yeah,
nor Dr.
it's
Srinivasan.
applicable to me also.
Yeah, that's what. Nor is Dr.
We have
Srinivasan.
self-learned, but of course we want to learn from you also.
Yeah, Snehal actually called me and told me today's session is on EEG and MRI. I said that means I'm going to learn from the students. And I'm very happy that 2 students, Dr. Akash and Dr. Mona Lisa, have chosen 2 difficult areas in general pediatrics. Okay. And I'm sure it will be a very good learning exercise from me. For a change, I think the doubts that I have, Dr. Akash and Mona Lisa are going to clarify today. Okay?
The indirect way of questioning, eh? Okay.
Yeah. Please go ahead. Please go ahead.
Is it visible, sir?
Yes.
Yeah. We're starting with EEG. So EEG are the electrographical record of the electrical activity of the brain, which are recorded by the different electrodes placed on the scalp. There is a standard system of electrodes which are put on the scalp, which is known as a 10 by 20% system. This 10 by 20% system of EEG electrode placements are in front of us. This is there are 3 anatomical landmarks: Nagivian, preauricular point, and Inion. With respect to this, any 2 of the anatomical landmarks, total distance, 10% of the total distance of the any 2 anatomical landmarks, electrodes are kept and labeled as frontal, then frontal, central, parietal, occipital, as shown in the figure. Then there are full names of all the
Wait,
electrons.
Dr. Akash, slow. See, these
Yes.
electrodes are kept
These
at
electrons are
different
yes,
places to record the electrical activity of the brain. Am I right?
brain. Yes, sir.
And their points are denoted as F, C, P, and O. Am I right? And T.
Yes, sir.
Frontal, parietal. What does C mean? Central.
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 It is
P
central.
means parietal. O is
Parietal.
occipital. T is temporal. Am I right?
Yes, sir.
Okay. What is the 10%, 20% that you depicted? What does that mean?
10% is the sir. 10% of the total distance between two anatomical landmark. That is
Yeah.
Naziv to occipit.
Okay. The neighboring electrodes are kept at 10% distance. Am I right?
Yes, sir. Yes.
Okay.
There are 21 electrodes which are placed on the scalp as shown in the figure. There are full names also for the each electrodes which are as follows. FP1 is frontopolar, FP2 is frontopolar 2. Then we have the central midlines, midline frontal, and mid frontal, right and left. Then central right, central left, and at the vertex there is a central also. Then there is a parietal 3 and parietal 4 and occipital 1 and 2. In this manner, there are 21 electrodes are kept placed on the scalp, and they get the activity of electrical activity of the brain and recorded on the graph as EEG.
Okay. 21 total of 21 electrodes are kept in different areas, starting from the frontal and ending up to occipital. Am I right?
Yes, sir.
Please go ahead.
This is the normal EEG in a child. This F1 to F1 and F7, F3, these are figures and electoral activities which are shown in the extreme left. This
How do you identify right and left in the EEG?
in the right and left, this F nomenclature given on the left side is the left, and in the right side given is of right.
Okay. Please show with the pointer.
This is left, and this one is right.
You're not pointing. I don't know. You're not moving your thing. Yeah. Which is the left and which is the right? Please go back. Which is left and
Yes,
which is right?
this is FP1 is FP1 is on left side, and then F7 is on right side.
Okay. Good.
Then EEG, we are looking what to look at the EEG background. We are looking at the background in the EEG. Background is a normal electrical activity of the brain. Then activity of the wave is it in a rhythm or any rhythmic activity, or the any periodic activity is there, and the evolution of new rhythm after a normal electrical activity of the brain. These three things we have to look in the EEG.
Go ahead.
EEG, there are certain waves we have to describe in the EEG. First one is a delta wave. This frequency ranges from 1 to 3 hertz. These are slow sleep waves for adults. Then theta waves are there. Frequency ranges from 3 to 8 hertz, which are these waves comes in the when child is in drowsy, and adults is also in drowsy condition. Then alpha waves frequency ranges from 8 to 13 hertz. Alpha waves comes when a person is relaxed with closed eyes or on any mental exertion. Beta waves frequency are 13 to 30 hertz, 30 hertz. Beta waves comes when a person is active or any anxious thinking or active concentration.
You have any picture of alpha and beta waves?
Yes, sir. Yes,
Yeah.
we have.
Yeah,
These
yeah.
first ones are beta waves. The frequency is 30 to 30 hertz. It comes basically from the frontal and parietal areas of the brain. We measure the frequency of the waves in 1 second. If the frequency lies between 30 to 30, then it is a beta waves. Then next waves are alpha waves. Alpha waves basically comes from the occipital lobe, and frequency of the alpha waves are 8 to 13. And alpha waves are like yeah, showing in the picture in the second line. Theta and delta waves are
Easy to
in the
remember. Easy. Just to remember, BP, beta waves are in the parietal region, and AO,
yes, sir.
alpha waves are in the occipital region. Easy to
Occipital.
remember. Yeah.
Yes, sir. Theta and delta waves are in sleeping conditions. And frequency of theta waves is 4 to 8 hertz, and delta waves is 1 to 3 hertz. So we have 3 to 4 cases for the discussion with respect to the respective EGs. First case is a 10 years old girl, developmentally normal, multiple episodes of brief staring looks for the 5 to 10 seconds, but there was no loss of tone or no episodes of unresponsiveness and no post-ictal phase. On examination, there was no positive neurological finding at the time of presentation. So the we have done the EEG. Then EEG was like this.
Please describe the abnormality.
This EEG shows the specific pattern of the spike and wave.
Can you show with a pointer
Yes, sir.
or move your cursor and show?
Yes, sir. These are the spikes and these are the wave. This is the characteristic EEG suggestive of the absence seizure. These are the spikes and wave patterns.
What is the frequency of this spike?
Frequency
And
3 hertz, sir.
okay, okay.
In 1 second, there are 3 spikes and waves are there.
Go ahead.
Then this is typical of the absence seizure. Typical absence seizures may come in the 4 to 10 years of the age group. There can be hundreds of episodes per day, which may prolong to 4 to 20 seconds. But in this absence seizure, eyes will be open and voluntary activity will be stopped. This EEG suggestive of the frequency of 3 per second spikes and wave activity. This test can be provocated by the hyperventilation also. After in the EEG checkup, we will do some provocation test. We can do some provocation test by hyperventilation. We can hyperventilate the child for the 3 minutes, and we can provocate the absence seizure. Drug of choice for the absence seizure is ethosuximide, and then second valproate and lamotrigine can be used.
No. Just a few comments on this slide.
Yes.
One is that ethosuximide is no more being used. Availability is poor.
Availability, but it's a very good drug because it's
Good drug, but valproate is equally effective. Equally
but
effective.
valproate because of the liver, this thing, enzymes may be raised. But we have seen valproate not control uncontrolled seizures have been responsive to ethosuximide. We had a few cases
agreed.
like that.
Yeah, agreed. Two or three important points about absence seizure. Absence seizure are an isolated presentation. It occurs in neurologically intact children with normal IQ, no other issues. And it's more common females, the prognosis is excellent. The outcome after a few years, it spontaneously resolves. It doesn't lead to any sequelae. It is not life-threatening, and it's an isolated manifestation. Children don't have any other neurological morbidity. These are some important clinical points about absent seizure, more common in female children.
Yes,
And many
sir.
times
And
absent seizure is picked up by the school teacher.
yes, sir.
Child,
Yes.
while in the classroom, will
Yeah,
suddenly.
Staring you.
Yeah, I
So-
always tell whenever student is not responsive and looking very vague, when we are teaching, I ask, have you to take EEG? So, the expressionless, suddenly if they are, not moving and looking that is very characteristic.
Yes, sir.
Okay.
And according to new classifications, absent seizures are classified as the generalized seizure and generalized non-motor seizures. New classification is.
Yeah, agreed. Yeah.
Then second case is there, sir. 5 months female child was there with a cluster of sudden tonic flexion of the entire body multiple times in a day, especially on awakening since 2 weeks. Then child presented after the seizure episode in the emergency room. We did the EEG after the post-ictal phase. Then EEG suggestive of these types of.
Spelling mistake, hypsarrhythmia, not hysarrhythmia, hypsarrhythmia.
Yes, sir.
Okay.
Yes, sir.
Point out the areas of abnormality.
This is the EEG conducted. EEG conducted after in the post-ictal phase. These EEG waves are suggestive of the high amplitude waves with irregular spikes in the various zones of the skull. Then this is called as a hips arrhythmia. This is especially special characterized in the waist syndrome. Waist syndrome
Means, yeah,
character.
mountainous type of this thing. Hips, that
Yes.
is hips.
Yes, sir. And waist syndrome is characterized by infantile spasm with a specific characteristic EEG features like hypsarrhythmia and the developmental delay or the developmental regression. Waist syndrome, infantile spasm with hypsarrhythmia. Hypsarrhythmia is a technical term. Abnormal interictal high amplitude waves and background of irregular spikes are there. EEG suggestive of high amplitude multifocal spikes and poly spikes, asynchronous and arrhythmic. Then drug of choice for the waist syndrome or infantile spasm are ACTH, corticotropin hormone, and steroids also can be given in these conditions.
Yeah. Few points about infantile spasms. If you do not treat it aggressively, persistent seizures itself is linked to neuroregression.
Yes, sir.
All seizures, the developmental regression will respond to your therapy. 1. 2. Your levetriston may worsen infantile spasms. Your levetriston might not work
Okay.
against your infantile spasm. You will have to go in for phenobarbital or for sodium valproate. Okay, multiple
sir.
antidepressants have to be used. And of course, today ACTH or steroids both have been found to be effective. And once you control the seizures, there is marked improvement in the prognosis with regard to development. And many of them may have associated neurodegenerative disease or neurometabolic disorder. And in contrast to extrapyramidal movements, which are notoriously common in children with developmental issues, your myoclonic seizures or infantile spasms may occur even during sleep. All the extrapyramidal involuntary movements do not occur during sleep.
Yes, sir. Okay. This infantile spasm has a classification. These are divided into two types. One is symptomatic and second one is cryptogenic. Symptomatic infantile spasm is defined as infantile spasm with the known cause and the significant developmental delay at the time of the presentation. Then we will call it as a symptomatic infantile spasm. It has three causes: perinatal, uh, antenatal causes, perinatal causes, and postnatal causes. And in the drug of in the management, newer development is there for the vigabatrin. Vigabatrin can be used as in the West syndrome after the ACTH.
Go ahead.
Third case is there. 7 years male child was there. Developmentally normal, no neurological issues were there. Nocturnal seizures, jerky movements of the lips, eyes, and wide open. Eyes are wide open, unable to sleep, and hypersalivation is there. This child presented after the seizure episode into the emergency. EEG was done. EEG was suggestive of these types of features. This EEG is suggestive of the certain unilateral.
Where is the
This
abnormality? What is the abnormality?
abnormality is there is spikes in the this EEG at the cerebral Rolandic area. Centrotemporal spikes are there in this EEG. This temporal regions and
Benign Rolandic epilepsy. Am I right?
yes sir, yes sir. In central area and temporal area there are the spikes with high voltages.
Very typical.
Yes sir, very typical. This centrotemporal spikes, benign Rolandic epilepsy of childhood. It is also called as BETS, benign epilepsy of childhood with centrotemporal spikes. This typically occurs in the age of the 1 to 14 years. Unilateral sensory motor seizures at the typically are the typical. It may associated with the hypersalivation and speech arrest. Prognosis of this condition is a good prognosis. Most remains in 2 to 4 years of the age. Treatment this initially treatment is not required, but if the episodes are frequent or it is focal seizures is converted into generalized or any complications occur, then we have to treat with the drug of choice is carbamazepine or levetiracetam, etc.
Yeah.
Steven-Johnson syndrome is more common, so better to use levetiracetam because it was not there earlier. Now with levetiracetam, the use of carbamazepine is less because we had 2 cases of Steven-Johnson syndrome. So it's better to use levetiracetam more than carbamazepine, though it's effective.
Yes.
Okay.
Yes.
Okay. In addition to carbamazepine, oxcarbazepine is another alternative drug. And the points that you must remember, whenever you want to start any child on carbamazepine, you should counsel the parents regarding the risk of carbamazepine hypersensitivity syndrome or Steven-Johnson syndrome, which
Yes, sir.
usually occurs 7 to 10 days or 7 to 15 days after.
After
And in addition to
onset.
Steven-Johnson syndrome, carbamazepine hypersensitivity syndrome is almost like your dress,
Yes,
which
sir.
occurs secondary to phenobarbital or
Hypereosinophilia
phenytoin.
and other things, yeah.
You can have eosinophilia, you can have hepatitis, you can have hepatosplenomegaly, pseudo lymphoma like your phenytoin hypersensitivity syndrome. Carbamazepine hypersensitivity syndrome can also cause rashes, fever, interstitial pneumonia, hepatosmegaly, etc. It should not be mistaken as exanthematous fever. It may start as early as 7 to 10 days. So any patient who started on carbamazepine or for that matter phenobarbital or phenytoin, you should counsel the family to return if there is fever with rash or cervical
Yes.
retinopathy or generalized lymphadenopathy.
Yes.
One of the most important causes of drug fever is all these anticonvulsants.
Yes.
Whereas your levetiracetam is pretty safe. But unfortunately, though levetiracetam looks like a good drug, there are increasing reports of hyperactivity. It is reported that even as high as 40 to 70% of children who receive levetiracetam may develop hyperactivity. It may worsen. So many a child with epilepsy may also have ongoing or hyperactivity, and it may be worsened by giving levetiracetam.
Levetiracetam. Okay.
But it is sad that phenobarbital, which is such a wonderful drug, okay, was discredited because of hyperactivity. But levetiracetam, which is supposed to be an excellent drug, is also notorious for hyperactivity. Only thing is, drug interactions are almost nil with regard to levetiracetam when compared to all other anticonvulsants.
Anticonvulsant.
There are two drugs in pharmacology. One is warfarin, another is phenytoin. Name any drug, they have an interaction.
Yes.
Please go ahead.
Yes. Fourth case is the 1-year girl child, developmentally normal, started with fever, high grade for few hours. Then tonic episodes of parent noticed a tonic episode of upper limb, spontaneous resolutions of episode at that time. Repeat episodes, similar types after 24 hours of the first episode, which is also having spontaneous resolution. But at the time of the episode, there was a fever, high grade fever spike. Then after 3 to 4 hours of the second episode, child had a third episode of in the hospital, which was terminated by intranasal midazolam. At that time also there was a fever spike. The child was loaded with levetiracetam. We did the EEG of the child. EEG was suggestive of this type of the picture. It is a EEG suggestive of the diffuse background slowing, which is due to the postictal phase and diffuse encephalopathy after the seizure. This was a case of atypical febrile convulsion. EEG was suggestive of continuous high amplitude posterior slowing, which was suggestive of the diffuse encephalopathy. Central shaft may not be epileptiform. There was no repeat episode of seizure after the third episode and after loading with the levetiracetam. Fever subsided. Repeat EEG was advised after the 14 days.
It is said that any child who suffers from a febrile seizure, you should postpone the EEG by 14 days.
Yes, sir.
If at all you want to do an EEG, if at all you want to do. Most children with febrile seizures don't require anything.
Yes, sir.
Okay. What is the definition of atypical febrile seizure?
Atypical febrile.
What is that? In other words, what is the definition of simple febrile seizure?
Typical febrile seizures. Yeah.
Define simple febrile seizures.
Simple febrile seizures, time limit is less than 15 minutes or less, and then single episode in 24 hours, spontaneous resolution is there. And
any other criteria, age criteria?
age criteria is 6 months to 5 years of age.
6 months to 5 years. And there should be no history of unprovoked seizure before.
See,
And the child should be developmentally normal. and there should be no metabolic abnormality. All these are criteria to say that the child has got a febrile
Febrile
seizure.
seizure. Yes.
Okay. Okay, somebody has put in the chat box a question. 1 minute, I'll just read out the question. Yeah, Dr. Pankaj Walker put a question. How to differentiate between Anaya-Tipolis syndrome with Rolandic? I don't know the answer. Sir, Professor Srinivasan sir, or anybody in the audience? I don't know. Probably only a neurologist. If there is anybody who knows the answer can put it. I do not know the answer myself. Okay. Go ahead.
Yes. So we are starting with the MRI, sir.
Okay. Sir, Professor Srinivasan, your comments so far.
Yeah. So this particular this thing, rolantic epilepsy and this thing, I think the spelling of that this thing, Panayati-Polis is wrong. I think. Of course, there is a syndrome which is
Hello.
Hello.
Yeah, Dr.
Hello.
Sneh Patel
anybody
has
who
put
is
in the chat.
this well versed in this syndrome, they can tell. Any neurologist?
Dr. Snehal Patel has put in the chat box. Definition of febrile seizure is being extended to as low as 1 month. Yeah, may I don't know. Honestly, I don't know. We will refer. You may be right, madam. I don't know. Okay. And okay. Yeah. Any other comments? Okay. Let us move forward.
Yes.
Well done, Dr. Akash Yadav.
Yes.
Yeah. I'll stop sharing. I don't know why my screen is coming as stop sharing. Yeah. Please go ahead.
Yes.
Good evening, everyone. I am presenting regarding basic overview of MRI. So, MRI, that is magnetic resonance imaging, it is one of the most commonly used tests in the neurology and neurosurgery. It is a non-invasive modality, and MRI provides the executive detail of the brain, spinal cord, and vascular anatomy, and has the advantage of being able to visualize anatomy in all the three planes, that is axial, sagittal, and coronal. So the mechanism is that MRI is a complex interaction between the hydrogen proton in the biological tissue, a static magnetic field in the form of the energy, that radio frequency wave induced by the coil that will be placed next to the body part of the interest. So the mechanism is based on the complex interaction between the proton in the human body, magnetic field, and radio frequency energy. So this is the physiological mechanism of the MRI. So coming to the some basic terminology that is frequently used in the MRI.
1 minute,
like-
1 minute, 1 minute. Please
Yeah.
go back to the previous slide.
Yeah. Yes, sir.
Can you explain
Yes, sir.
what is used to get the image? You have put complex interaction.
Yes, sir.
Interaction between protons and then magnetic field.
Magnetic field.
How does it get converted into an image?
So the radio frequency wave that is like we are giving through the magnetic field that will detect the biological tissue and the interaction of the like proton in our tissue and the hydrogenic interaction that will be that will be converted into a like our required form of the image.
Okay. What
So-
is used? Basically, it is a hydrogen which interacts with protons. Am I right?
Yes, sir.
Okay. Go ahead.
So coming to the basic terminology that is frequently used in the MRI, like high signal intensity that will be white, intermediate signal intensity that will be gray, low signal intensity that is black. In the term that is hyperintense, isointense, and hypointense. So hyperintense that if it is brighter than the things we are comparing it to, isointense is same brightness as the things we are comparing. and hypointense is that darker than the things we are comparing it to. So these are the terminology that are frequently used in the MRI imaging. So coming to the various sequencing or like modalities used in the MRI, like T1 weighted, T2 weighted, FLAIR, DW, all these are various sequencing we normally use in the MRI. So coming to the T1 weighted imaging. So T1 that is one tissue appears to be bright, that is for a mnemonic, like that is fat. So in the T1 weighted, only fat appears bright, all rest are gray. So in the T1 weighted, the white matter that is brighter than the gray matter. The white matter that is brighter than the gray matter. And the like dark in the T1 weighted image, CSF, edema, bone tumor, infection, inflammation, hemorrhage, calcification, all these are dark on the T1. And only the fat and subcutaneous hemorrhage that are brighter in the T1 weighted image. So basically, T1 weighted image that is providing a good gray and white matter anatomy, anatomy differentiation can be made by the T1 weighted image.
Okay, in other words, T1,
Yeah.
the CS, one minute. See, T1, the
Yes,
CSF
sir.
is black. CSF is black.
Yeah. Yes, sir. CSF is black. White
Yeah.
matter is
And
brighter.
fat is
and
bright. Fat is bright.
Yes, sir. Fat is brighter. All rest are like
Okay.
dark, and white matter is brighter than the gray matter.
Okay.
Then, sir, coming to the T2 weighted image. So here the gray matter brighter than the white matter. As you can see that the gray matter is brighter than the white matter. So here T2 like mnemonic 2W will be white. For example, like the CSF that is a water for mnemonic. So anyway, brighter T2 is like CSF, edema, tumor. All these are brighter in the T2. Subdural collection all will be brighter in the T2 weighted image. So dark T2 will be calcification and the fibrous tissue. All these are dark. Otherwise, CSF and all the edema all will be appear brighter in the T2 weighted image. So this is the T2 weighted image. Then next, sir. So this is like for the contrast enhancing study. Generally we use the gadolinium contrast. So it is a picture showing T1 weighted imaging can also be performed while infusing the gadolinium. So the advantage of using the contrast enhanced T1 weighted is that like the gadolinium is very bright on the T1 weighted images. So gadolinium enhance the images, especially useful in like seeing the vascular images. For example, here the vascular pathology are well visualized even in the T1 weighted image, but using a contrast like gadolinium. So it will be helpful in it will be useful in looking at the vascular structure and the breakdown in the blood-brain barrier like tumor, abscess, inflammation in HSV, encephalitis, multiple sclerosis. All these things, if the blood-brain barrier is broken, so at that time by looking at the blood vessel structure using the contrast, we can see in the T1 weighted images. So this is the normal T1 weighted in the enhanced T1.
Yeah, in other words, when you give gadolinium, what happens that the T1 weighted images become more prominent. Am I right?
Yes, sir.
And then this is how you pick up a focal lesion like an SOL, a tumor, an abscess, or areas of inflammation due to encephalitis, etc. Am I right? Or even
Yes, sir.
non-infective lesions,
Yes.
anything which is inflamed, anything which has a tumor, anything which has a pus
vascular blood supply.
will appear better with gadolinium contrast in the T1 weighted image. Am I right?
Yes, sir.
Yes.
Okay.
Coming to the next variety, that is a FLAIR. FLAIR, it is a fluid attenuated inversion recovery. So it is similar to the T2 weighted image. Here the abnormalities remain bright, but the normal CSF fluid is attenuated and made dark. So in a short, it is like FLAIR is nothing but T2 plus CSF is dark. It is same as of the T2, but only difference is that the CSF is appearing dark here. So it is used for like periventricular and subcortical abnormality, delineation of the lesion near the ventricle, differentiating a epidermoid from the arachnoid cyst, diffuse axonal injury, and in the stroke, most importantly in the stroke, hyperintensity on the flare that will be like the stroke will be visualized even within the 4 to 6 hours of the injury, but that will not be visible in the T2. So that is the advantage of using the flare, because we are like activating the CSF, so all the abnormal structure will be visualized instead of the CSF. So this is the flare image.
Typically, the flare image picks up the most common type of cerebral palsy like periventricular leukomalacia. Am I right?
Yes, sir.
Yeah, because it is, I mean, the CSF is dark, but around the ventricles, if you want to pick up lesions, the
Yes, sir.
best image that you can use is the flare image,
Flare image.
Flare
pick
image.
up periventricular leukomalacia, which is the most common finding in spastic diplegia.
Spastic
Am I right?
diplegia. Yes, sir.
Okay.
The flare. So coming to the comparing the three variety of MRI, like T1 weighted, T2 and flare. In like CSF, T1 weighted it will be dark. In the T2 it will be white, like bright, and the flare it will be dark. White matter, T1 weighted that will be light, like more white, and T2 weighted this will be dark, and in the flare also it will be dark. Cortex that is it will be appear like gray, and in the T2 flare both will be like gray, and inflammation infection all will be in T1 weighted will be dark, in the T2 it will be bright, and flare is also bright. The only difference between T2 and flare is that is the only CSF
is black.
black. Otherwise both are completely same. And the T1 is mostly used to differentiating and to get the physiological anatomical differentiation of the gray matter and white matter. So that is the use of the T1, and here is the T2 and flare. So this is the comparison slide. Then coming to the third variety, that is diffusion weighted imaging, DWI. So this is designed to detect the random movement of the water proton. So diffusion weighted imaging is like it is based on the principle of the diffusion. For example, like it combines the T2 image with the diffusion of the water. So when the water molecules diffuse freely, in this process, the water molecule that will be freely diffused into the extracellular space, but it will be restricted in the intracellular space. So spontaneous movement, that is diffusion, rapidly become restricted in the ischemic brain injury. In the ischemic brain injury, the water movement will not be there, so it will be detected in the MRI. So during the ischemia, the sodium potassium pump it will be shut down, and the sodium accumulate intracellularly. So water shift from the extracellular to the intracellular space due to the osmotic gradient. As the water movement becomes restricted intracellularly, so this result in an extremely bright signal in the DWI. So DWI is extremely sensitive method for detecting the acute stroke. So this is the benefit for the DWI, like this slide. This slide. In the even flare imaging, the acute stroke is not visualized, but in the diffusion weighted MRI, the acute stroke is easily visible. So this is the difference and advantage of using DWI image. So other uses of the DWI, that is positive DWI, is found in areas of the cytotoxic edema, brain abscess, acute encephalitis, and acute demyelination. And the principle in all the cases are same. That is the diffusion of the water. When it is restricted, then it is easily visualized in the MRI plane.
In other words, flare picks up a lesion which had taken place long time back, like PVL, whereas your
Yes,
DW picks up an acute event like a stroke. Am I right?
Yes, sir.
Okay.
So coming to the MRI spine, so this is a small comparison slide between the T1 and T2 weighted MRI of the spine. So how to differentiate between a T1 and T2? Like the CSF. In the T1 weighted, the CSF around the spinal cord, that is the dark color, but here the CSF is white color. So this is the T2 modality and this is the T1. And in the T1, the muscle will be gray, and here the muscle will be dark gray. So T2 that will be more darker side, and the spinal cord that will be gray, and in the T2 it will be light gray. So main differentiating feature is the CSF. In T1 it will be dark, and T2 it will be bright. And in the inflammation, all the inflammation in the T1 weighted that will be appearing like dark, but in the T2 weighted it will be bright. So it is the differentiating feature between a T1 and T2 spine. So coming to various cases and its specific MRI associated with it. So, case 1, 10-year-old male child presented to ER with complaint of headache since last 4 days, which increase in intensity since last 1 day, multiple episode of projectile vomiting since last 1 day. On neurological examination, right-sided hemiparesis is there, no history of injury or fever. So, the patient is advised MRI. So, on MRI, it is suggestive of large space occupying heterogeneous enhancing lesion, that is also midline shift is also there. So the size and the locality and the midline shifting nature of the lesion is more likely suggestive towards like neoplastic etiology, maybe glioblastoma multiforme. So coming to the glioblastoma multiforme, GBM, it is a grade 4 astrocytoma. Though it is rare in pediatric age group, otherwise it is also called as death warrant tumor because the prognosis is very poor with median survival rate of 12 months. So its diagnostic modality is MRI, then the surgical resection of the tumor and the biopsy study. Then after that, the treatment wise, the adjuvant chemotherapy with temozolomide, that is the alkylating agent, which mechanism of action is methylation of the DNA. Concurrent radiotherapy, that is only for palliative modality. So this is the typical of the glioblastoma multiforme MRI, otherwise also known as the butterfly lesion in the MRI. So there is a large tumor, midline shift is also there, and so this is the MRI of GBM.
Okay, what are the differences in the clinical presentation of a child with a supratentorial neoplasm in contrast to a child with infratentorial neoplasm? SOL,
Yes, sir, yes, sir.
supratentorial versus infratentorial, what are the differences in the clinical manner? That is what is important for a general pediatrician or a clinician.
The eye sign is the supratentorial, the parietal lobe will be affected in
To make it very simple,
yes, sir.
supratentorial is more often associated with focal seizures, right?
Okay.
Psychiatric disturbances, intellectual problems, okay, and a focal deficit like monoplegia or hemiplegia. On the other hand, an behavior disturbance is more common in supratentorial seizures. Okay. On the other hand, an infratentorial neoplasm may present with ataxia, signs of raised ICT, lower cranial nerve palsies, respiratory difficulties, autonomic disturbance. These are the differences between supratentorial and infratentorial. In general, the younger the child is, more are the chances of infratentorial neoplasm. For example, papilledema is much more common in infratentorial than compared to supratentorial. Ataxia, raised ICT are more common in infratentorial. Please go ahead.
So this is the case 2. A 5-year-old female child brought to the hospital with complaint of low-grade fever since last 2 days, headache since 1 day, decreased activity since 1 day, altered sensorium since 2 hours. On examination, the neck region is present and meningeal signs are also positive. So all these like clinical signs are more suggestive towards the meningitis, but to rule out other causes or possibility of the altered sensorium, we did MRI. So here the MRI is suggestive of mild meningeal enhancement. So the small area of meningeal enhancement is also there in the right anterior parafalcine region. So this is more likely suggestive of meningitis. So meningeal enhancement, but that is difficult to pick up in the MRI most of the time. But here the meningeal enhancement is visible. So this is suggestive towards meningitis, though it is not a diagnostic modality for a meningitis. But to rule out the other like possibility of the altered sensorium, we did the MRI for this child.
Okay, I have a peculiar question. You
Yes,
use
sir.
the term meningitis. What is the meaning of meningitis? What do you mean by the term meningitis?
The inflammation of the meninges.
Which there are three meninges.
Left
Dura is
Left
there,
meninges.
pia is there,
Yeah.
arachnoid is there. Which mean all meninges are inflamed, or only one is inflamed, two is inflamed, three is inflamed.
leptomeninges. Oh,
How many? What are
pia
the types of meningitis?
Pyometer, no.
See, strictly speaking, when you say meningitis, we usually refer it to leptomeningitis. Dr.
leptomeningitis.
Aisha has put in the chat box. Dr. Yeah, Aisha Jabin, she has put lepto. Yeah, she is right. When there is inflammation of pia and that is pia and arachnoid, you call it as leptomeningitis. When there is inflammation
Leptomeningitis.
of dura, you call it as pachymeningitis. All the layers are involved. It is called pachy. The meningitis that we see, your pneumococcal meningitis, H flu meningitis, is all leptomeningitis. Only unusual organisms like syphilis, tuberculosis, okay, can cause pachymeningitis, involve all the layers,
Yes.
Okay, when you say
Oh.
meningitis, what you mean is leptomeningitis.
Leptomeningitis.
Okay, go ahead.
Sir, I have a query.
Yeah.
So
Yeah,
sorry
you
for
have.
joining late because of another meeting. I missed EEGs. Sir, they said students, you're saying that it was not an indication for MRI. So I just wanted to ask that what would be the indication, real indications for MRI, and sir, to guide us, especially in cases of meningitis when you suspect clinically.
Indications for MRI in meningitis, is it?
Yes, so they said that it is not a real modality. No, so I just asked that what are the real indications and other cases where when you do MRIs.
Yeah, the question is to me or to
Can I
the
tell?
student?
Actually, if there is any focal neurological signs in a child with meningitis, proven meningitis by CSF, etc., there can be an abscess in association or some other complication. So sinus thrombosis, etc. So if there is a meningitis already proved by CSF study and clinical findings and the clinical signs, it may not be necessary. But if there is any onset of new focal signs, etc., we have to immediately do MRI. Am I correct, Dr. Bala?
Yeah, sir. One should consider neuroimaging. When I say neuroimaging, the choice of investigation is MRI rather than CT. But many a time you may not have in your campus facilities to do MRI, in which case you can do a CT. Number one, you should consider CT when there are signs of raised ICT.
I see.
There's no doubt at all. When there are signs of raised
Raised
ICT,
ICT.
when you say signs of raised ICT, it includes even a focal neurological deficit. Okay, papilledema, cardiorespiratory compromise. Definitely, you will not do lumbar puncture without doing a neuroimaging. And in emergency, CT scan is definitely helpful. But if it's an elective MRI, that is number one. But for meningitis, when you are not sure about the diagnosis, for example, you have a child who has prolonged fever, 2-3 weeks of fever, and the child has got meningeal signs. The differential diagnosis will start from tuberculous meningitis to brain abscess. In such a case, you will always consider a neuroimaging.
Neuroimaging before
MRI
the CSF.
is the investigational choice. While treating a child with meningitis, if the child has possibilities of a subdural effusion or ventriculitis or hydrocephalus, definitely you should consider neuroimaging, preferably MRI. For example, when will you suspect subdural effusion? Persistent fever, bulging fontanelle in a young infant in spite of good treatment, focal deficit, focal seizures, okay? And of course, old days we used to do transillumination. Nowadays we don't do, right? We do MRI. Okay.
Okay,
These
sir.
are all the indications. And when you are thinking of an alternative diagnosis, When you say alternative diagnosis, it includes an SOL, it includes tuberculous meningitis, it includes a
Tuberculosis.
brain abscess. Brain abscess. Under these
Yes.
conditions, you always consider doing an imaging.
Imaging.
Yes, sir.
Okay, Sneha? Yeah.
Yes, so
Please
yes,
go.
just wanted to make the point specific. Yeah.
Okay.
So coming to the case 3, 13-year-old female child brought to the ER followed by a road traffic accident. So severe injury on the head with severe bleeding. Right forearm fracture is also present. Multiple abrasion injury on the body. On examination, the GCS was around 12 by 15. So urgent MRI done. So the MRI suggestive of right thalamic hemorrhage with intraventricular extension to the right lateral ventricle, showing mainly hyperintensity on the T1 flare image. So this is typical of intracranial hemorrhage, showing the bleeding around the thalamic region, and it is extending to the intraventricular region also. So this is the typical. We are doing the flare imaging. So just to rule out, just to look the CSL. So the CSL will be appearing dark. So it will be easy to get the hemorrhage in the brain.
Please go ahead.
Yes, sir. Coming to case 4. So this is a 7-year-old boy presented with complaint of low-grade on and off fever since last 20 days. There is a history of weight loss since last 15 days, mild grade of headache since last 10 days, with increase in intensity since last 2 days. So severe periorbital pain and focal neurological deficit started since last 5 hours. And there is a family history of TB is also present in this case. So then to rule out the tuberculosis, we just did MRI with suggestive of in the T1 weighted MRI, it is suggesting of one ring enhancing lesion is there in the cerebellum. Another coronal section showing supratentorial and infratentorial cerebellar ring enhancing lesion. So here two ring enhancing lesion are there. So either this may be tuberculoma or neurocysticercosis. So to rule out, make a difference between the two, like tuberculoma and neurocysticercosis, in both the cases, in the MRI, ring enhancing lesion will be there. But in tuberculoma, the size is normally large, that is more than 2 centimeter, and usually it is multiple. But single large enhancing lesion may also be present in the tuberculoma, but mostly it is multiple. And in the neurocysticercosis, the size is usually low, like 2 centimeter, less than 2 centimeter, maybe single or multiple. Then second differentiating feature is it is associated like tuberculoma associated with basal meningitis or hydrocephalus, and neurocysticercosis there is no such association is there. In the clinical sign, both fever is also there in tuberculoma and neurocysticercosis. Weight loss history is also may present in the neurocysticercosis also. And to rule out both, tuberculoma more common in the posterior fossa, whereas the neurocysticercosis, the ring enhancing lesion are more commonly at the gray white matter junction. And in the tuberculoma, the scolex, the hypointense scolex will not be there. But in the neurocysticercosis, in the T2 weighted MRI, hyperintense scolex may be present. And the midline shifting is more common in the tuberculoma, but midline shifting is not there in neurocysticercosis, as the enhancing lesions are mostly towards the gray and white matter junction. And one major difference is that MR spectroscopy show lipid peak in the tuberculoma, but in the neurocysticercosis, there is amino acid peak. So this is the typical features differentiating between tuberculoma and neurocysticercosis. So depending on this, the treatment modality will also be changed. Like for tuberculoma, we have to give steroid and anti-TB treatment. And neurocysticercosis, the treatment is albendazole, though it is the treatment, the prognosis wise is not that much good, but tuberculoma that will be curated. And both are chronic disease, so we need to differentiate by seeing the MRI. Both are typical ring enhancing lesion, and the MRI is the diagnostic modality to give a differentiating feature between the two diseases.
That is this thing, Orchestra of Research Children Education and Practice. Dr. Adi Shivam from Jipmer. Both children from the same family came from Trichy. This child had almost Ori sky appearance, multiple cystic lesions in the brain. So
Yes.
that's, yeah.
So this is complete here. It is completed the MRI discussion. So.
Yes, both students did justice to the topics allotted to them with good cases. So, Dr. Bala.
Bala sir, actually I'm trying to unmute, but he's not getting unmute.
Yeah,
Bala
but
sir.
of course, they have this thing, and it's very important because there are always in the OSCE stations, there will be one or two MRI or other neuroimaging, and these things which you have mentioned are very important for all the postgraduates. Okay, so you have to, of course, constantly see also, not only just read, but also you must constantly keep in touch with every child who is having MRI in your institution. You must immediately try to go and see. Okay, just like ECG. That's how we have learned ECG during our undergraduate and postgraduate days. Of course, those days we didn't have MRI scan or CT scan. So every opportunity you must not miss and try to instead of reading straight away the thing, you must try to interpret. Then you check whether it is correlating with the reported image. Okay, that's very important.
Yes.
Bala
Sir
sir,
is
I have
not
made
able
you
to
host.
join, I think.
You can just try one more time.
Any other consultant would like to give their comments before Bala is there?
See, Bala sir is not able to unmute, but he is the host now because sometimes the settings has to be in his hand. So maybe what we can do is, but sir, if he left, no, everything will be stopped then. Akash, you are a host now. You can just try to unmute, sir.
Okay, sir.
No, sir is rejoined again. Rejoined. Just a minute. Just a minute.
Earlier, Nivedita was there. I thought she will comment, but she is not there. No. Initially, she had logged in, Dr. Nivedita of Railways. So they have regular this thing, MRI sessions.
I think sir are rejoining.
Yeah, but he is not able to unmute. I think Akash, you can just try to make him because you are a host now.
Sir, but sir not visible there. Okay,
No, he's there. He's there. I think some setting problem is there. Hello.
Yes, sir. I'm
Can
trying,
you
but
make
it
me
is.
host? Can you make me host?
Any
Yes, sir,
other
I-
this thing presentation? I think both of them are finished, no? Presenting.
Yes,
Yes, sir.
yes. Sir.
So if Bala has already given all his comments, but I think
Yeah, he's,
if it is
sir is
time, we
not
can
able to
close it.
unmute because of some setting problem. I think
Yeah.
I'll just try one more time if you just me allow. So Akash, you can make me host. You can just go on the settings,
Yes, sir.
that participant, and just click on me and just make me host.
Done, sir.
Yeah. I think some system problem. I think I'm not able to unmute him.
I'm also, sir, not able to.
Yeah. I think some problem with the device only, because rest I can unmute, but sir, I cannot able to unmute.
Dr. Satish, but anyway, I think the topic is finished, right, today?
Yeah.
I joined
So,
late because of another
Points,
meeting.
most of the points he has made in each and every slide. In
because
case
he's
the
not
time
able
is
to
up, I
start the
think you
video
can
also.
close
Sir
it.
is not able to start the video also.
You can hear me, no?
Yeah.
Yes, sir. Yes, sir.
So I think they have presented well, and they have given all the basic information necessary for interpretation of MRI and CT scans. And of course, they had representative cases. They have done it very well. And of course, Dr. Bala has given all his inputs. So I think if it is time, we can close it.
Yes,
Of course,
sir.
they are given the inputs, but it is for the individual students to get familiar with it, and also if these presentations are available, they can of course use it. Is it available in YouTube for PGs?
Yes.
Yeah. So they can, unless they constantly see, and then of course we have mentioned all the differences between the various modalities of CT scan interpretation, MRI, various this thing, and they have done it well. I appreciate your sincere efforts you have put in. And only thing is we have to constantly try to read and then interpret, then try to see the report, whether it coincides with what your interpretation. Then only we can improve in
Yes, sir.
analyzing that. That is the message, of course.
Yeah, sir has said that you just send the slides on the group. I will send it to sir. And Dr. Satish, I think we can we have, if the topic is finished, we can
We'll
close
stop.
down. Good night, all. Sorry for joining late for because of another meeting.
No problem.
But next time you have the students who are presenting for the
Yeah, of
case.
course,
Please be
Dr.
ready.
Tangevelu also is, and is neurosurgeon, neurophysician, pediatrician. They have given a recent talk. It is available in this thing, YouTube. So they have given
Okay, sir.
extensive pictures. If you have interest, you can go and read that, because they have
Yeah,
conducted
yes, sir,
OSCE
yes.
So you can
station.
send me the
Yeah.
link. I will forward them on that group, student group.
Yeah, the YouTube, it is available on the Navi Mumbai IIP group.
Yeah, it is available on the
Okay,
YouTube.
okay,
Yeah.
okay.
Thank
this
you.
is
Anyhow, I
recorded,
can
huh?
also try to help.
Yes,
Okay, thank you.
Thank you all.
Okay.
Good night.
Thank you, all
Good
of you.
night. Good night.
Thank you,
Thank you
Akash.
so
Thank you,
much.
Monanisha. Very nice
Thank you.
presentation.
Thank you. Thank you.
Thank you, sir.
Thank you, Srinivasan sir. Good night. I think we have to say good
Good
day
night.
to sir.
Thank you.
Good
Thank
day,
you.
good day.
Yeah. We have started enjoying watching in the sunshine. Yeah.